Welcome to Clinical Lab Chat, part of the MedCore Podcast Network. I'm Chris Wolski, Director of Business Intelligence for CLP, and today we'll be discussing why C. diff should be at the top of your diagnostic minds. Joining me today is Christian J. Lillis, the co-founder and executive director of the Peggy Lillis Foundation, which is a nonprofit raising awareness of C. diff and advocating for patients with the infection. Christian uses his platform to promote the ongoing research and funding needed in the antimicrobial resistance space. And we'll talk a little bit more about what the Peggy Lillis Foundation does in a minute. So Christian, welcome to Clinical Lab Chat. I'm really glad we're going to be having this conversation about an infection that should be, but isn't more widely thought about and prioritized on the diagnostic menu. So let's get into it. So how about a little diagnostic background? I know that C. diff is, we've written about it on CLP. I know C. diff is relatively difficult to diagnose. And so why is that? And what are some of the other challenges related to diagnosis? I know you have some, we'll talk about some of your personal experiences regarding that as well in a minute as well.
Well, thank you so much, Chris, for having me. I'm always happy to talk about C. diff and particularly aspects of it that are underappreciated, like the role of diagnostics. So one of the challenges of diagnosing C. diff is that, we can have C. diff bacteria in our bodies. The nature of C. diff is that it is a spore-forming bacteria, and so when it's in harsh conditions, whether that's outside of the body or under attack by antibiotics, it can form these spores, which I always tell people it's almost like a pine cone nut,
Yeah.
So, it becomes forms this hard protective shell, which can survive, for months or years outside the body, can survive a lot of antibiotics. That particular thing doesn't really make us ill, and there are many of us who have that bacteria in our body, but in such a low amount that it doesn't make us sick. Right. The problem becomes when you have, an overgrowth of that bacteria, of the C. diff bacteria, and in reproducing itself, it gives off toxins, and those toxins are poisonous to us, and they damage the cells in our colon. So we have two kinds of tests. We have one test which detects the DNA of the C. diff bacteria itself, which would, spore form, vegetative state. That, in some cases, ends up with people being diagnosed with C. diff who only are colonized. And then we have the second kind of test, which tests for the toxins, and the toxins that it gives off as it's reproducing. And so in general, you can miss people with a toxin test because the toxins degrade over time, the sample wasn't stored well enough. But you can also overdiagnose people if you're just using a PCR type test. So ultimately, the diagnosis is a clinical one where the doctor looks at the result of the two tests, or one or both of the tests, and then the rest of your medical history. Have you recently had antibiotics? Are you in chemotherapy? What are the other risk factors you have? Do you have fever? Like, are there other things that they can say that would help them to diagnose you? And unfortunately for the many people suffering, with C. diff, we don't have a sort of, like if you test somebody for strep, they either have strep or they don't.
Right.
And there's not really any ambiguity. So it's unfortunately not quite as binary.
Yeah, so the challenge, it sounds like what the biggest challenge is diagnostically is that it's not just, as you said, it's not just a blood test or I think a stool test is also could be involved. You also have to have a good clinical diagnostician working with you as well to ask you lots of important, almost be like a detective and ask like a really good questions.
Yeah, and you mentioned, what are some of the other challenges around diagnosis? So one aspect of it is that C. diff is a poorly understood, poorly recognized disease in the U.S. and in many countries, where only about 30% of Americans have heard of it. So, the primary symptom being diarrhea is something that, we get diarrhea from eating something that just doesn't agree with us. We get diarrhea from viruses, from, all kinds of things. So it's a very, it's like running a temperature. There's a whole host of reasons you can run a temperature. So it's
Right.
not the greatest, indicator of what specifically is wrong with you. And on top of that, until maybe 20 years ago, C. diff was largely, and still is majority, an illness that impacts elderly people, people over the age of 65, people who are immune compromised. So when a younger, healthier person shows up with diarrhea, C. diff is one of the last things the doctors see.
Right.
The doctor will think about,
Right.
even though the trends in epidemiology is that it is affecting younger, healthier people.
Right. All right. So, what does the Peggy Lillis Foundation do to raise awareness for C. diff? We had a little pre-interview. I know my listeners know that we do pre-interviews. We talked quite a bit during the pre-interview. I read up on your website some of the things that you do. But so this is a passion of yours, and it's for a personal reason. And so, could you talk a little bit about what Peggy Lillis Foundation does to raise awareness, and a little bit about that personal connection that you have to the disease?
Yeah, well, let me start with the personal, because I think then it will sort of give the audience a sense of why awareness is so passionate for us. And so,
Right.
My mother, for whom Peggy Lillis Foundation is named, in April of 2010, she was a healthy 56-year-old kindergarten teacher in Brooklyn. She went to her longtime dentist, our longtime family dentist, and she had a root canal, and prophylactically they prescribed her an antibiotic called clindamycin.
Okay.
Now, some people in the audience may be going, oh, clindamycin, because that's what people, once they know that somebody's had C. diff, they know that clindamycin is one of the riskier antibiotics for it. And 3 or 4 days into taking the antibiotic, she developed, kind of severe, urgent diarrhea going 10, 15 times a day.
Oh, wow.
But being a kindergarten teacher, she just assumed that she caught something from one of the kids.
Right.
No matter how healthy you are, I don't know if you have kids, Chris, but I have a 6-year-old nephew, and I can attest that they are germ wagons. And
Oh,
so,
yeah.
you can be the
Yeah.
fittest person in the world, and if you're around little kids
Yeah.
and that little kid goes to school 5 days a week, like,
Yeah.
you get something a couple of times a
Sure.
year. So she was not really even concerned about it. And unfortunately, she didn't improve. That the following Tuesday, I took her to the hospital because I was concerned that she was dehydrated just from having 4 days of diarrhea.
Right.
And once we got to the hospital, within 30 minutes of us being there, the doctors having taken her history, they said that, she was severely ill. She was going into septic shock. Her white blood cell count was 40,000. She looked like she was going into kidney failure. And despite these doctors, and obviously, white blood cell count, all this other stuff, they told us that they suspected that she had toxic megacolon caused by a bacteria, back then Clostridium difficile, and I had never heard of it. And I had worked in healthcare. I'd worked in radiology as like a patient relations staff person. I had worked for 5 years at NYU Langone Medical Center in fundraising. So I was not somebody who was sort of, and to have never heard of this was kind of shocking to me. And very sadly, despite the best efforts of the doctors, my mother died the next day from sepsis.
Wow.
And, my mom had been a single mother from the time I was 5, and my younger brother was 2. And she had us young, and so, we thought, oh, we're going to have our mom until we're in our 60s, maybe.
Yeah. Right.
And so to lose her when I was 36 and she was only 56 was shocking, was horrifying, and And we started digging.
Yeah.
What happened? How did this happen? How do we lose our mother from something we've never heard of? This doesn't make any sense.
Right.
And we found at that point that about 15,000 Americans were dying from C. diff every year. More recent estimates are that it's somewhere between like 28 and 30,000.
Oh,
and
wow.
whether it's the primary cause or a sort of contributing factor in someone's death. And I was blown away.
Yeah.
Primarily because when you look at some of the other things that we've had enormous public health interventions around, like
Yeah.
driving under the influence, HIV/AIDS, we now lose fewer people to HIV every year than we do to C. diff or to driving
Wow.
under the influence. So, so for us, the main thing was like, how many other families would have taken her to the hospital sooner? Would she have said, could this be C. diff? So the awareness of just getting people to understand that this disease is out there, and it is the number one healthcare associated infection in most healthcare facilities. So that was what initially drew us to awareness, and when we started the foundation, that's really what we focused on. And over the years, we've grown, give you some early examples, we had a letter to the editor in the New York Times in like 2014 correcting their number that was in an article
Wow.
that they wrote about C. diff. We were in 2016, my mother's story was included in a cover story in USA Today about C. diff. Probably one of the most prominent stories that's happened.
Yeah.
Consumer Reports, all these things. And then in 2018, we started doing an annual public awareness campaign every November, because November is C. diff Awareness Month, called C Diff.
Right.
And through the internet and social media and pitching patient stories
Yeah.
to national and regional outlets, we have reached tens of millions of people over the past 5 or 6 years. And our goal is that, particularly if you're taking an antibiotic, if you have a loved one who's going through chemotherapy or something that can suppress their immune system, or you have an elderly loved one who's in a nursing facility or has recently been hospitalized, that when that person has diarrhea that doesn't resolve in 24 hours, think, is this C. diff?
Yeah. C. diff. Yeah.
And get
Yeah.
help, and
Yeah.
say, could this be C. diff?
Yeah.
So that's a big part of our work, and of course we can discuss other things that we do, but our goal is to have people see C. diff in all the different
Right.
ways that it can exist.
Right. Now, you talked about kind of your public outreach just now, and certainly that makes sense. Get into, we've seen this a number of times where, certainly patient-driven or grassroots-driven movements have helped with getting the scientific and the medical community on board. You mentioned HIV/AIDS. I remember back in the 80s, a lot of the activism around that, and I think that did a lot to help get the word out and get the medical and scientific communities really on board there, and the government as well. So to that end, you just sponsored a virtual C. diff scientific symposium. So you're now moving kind of into that world. Like, how'd it go, and what were some of the bright spots related to diagnosis or treatment that came out of the proceedings?
I think it was a wonderful event, and the feedback we got. So it was a virtual symposium.
Right.
Our goal was to get 250 clinicians, patients, folks from industry. We ended up with about 440.
That's great.
That registered, so almost double what our goal was. And what we did is the symposium featured relatively short lectures, 15 to 20 minutes.
Okay.
And we really did have kind of, if there is a sort of star cast of C. diff in the U.S.,
Sure.
of C. diff, clinicians and researchers, we had all of them. And I think that
Cool.
was, a testament to how PLF is respected in the space, but also to, these clinicians and researchers' commitment to this sort of underappreciated disease. And we had several talks that touched on diagnosis, everything from Alice Gu from the Centers for Disease Control talking about the epidemiology of C. diff and how that's shifted over the past few years. We had Dr. Eric DeBerkey from Washington University Hospital, who did an entire section on diagnosing C. diff. And then we also had a pediatrician talk about C. diff in children, which can present differently. We had a panel discussion moderated by Dr. Paul Feuerstadt and having Dr. Stu Johnson representing the Infectious Disease Society of America's guidelines and Dr. Colleen Kelly with the American Gastro Association guidelines, and they sort of talked about what the differences between those two were, and a little bit of it did touch on diagnosis. And then we had even presentations on like the difference in enzyme immunoassay testing versus PCR testing. So it was quite full and a lot of talk about diagnosis. And then we were also excited that we had not just people talking about the current treatments, but also, forward-looking treatments and forward-looking preventative stuff. So, there was the system that we hosted on has rate this symposium, and we got a 9.6 out of 10. So
wow, I take that as a win. Well. Yeah, I take that as a win for sure. So, we talked about this in the pre-interview a little bit. 70% of all medical decisions are made in light of clinical diagnostic tests. And we talked about this during the pre-interview that I just recently had my annual, and my guy has a checklist that he goes through, making sure that I'm being tested for all the right things. And why isn't C. diff part of that regular diagnostic, let's not say menu, but mindset? So as you said, if someone is presenting with diarrhea or symptoms for 24 hours, why isn't that the first thing on top of clinicians' minds? Or is part of the issue too, you're talking about getting it out to, people like you and me, understanding like, hey, if you have an issue not resolving quickly, get there, suggest that might be an issue. Is it also part of what you need? That part of what we need to do is that the clinicians, particularly those frontline guys, maybe in the emergency departments or your general practitioner, get that more in the front of mind as well.
I mean, yes to all of that.
Okay. Short answer, right?
Yes. All. If we could have all of that, that would be great. Yeah. I mean, so I'm not a scientist or a clinical person.
Neither am I.
I've learned a lot over the years, and to kind of sort of make me irritating to both those groups of people.
Right. Sure.
But prior to this, I worked primarily as a fundraiser for nonprofit organizations. I worked a lot in LGBTQ rights. I worked a lot in healthcare. I mentioned working at NYU, and so like my approach to considering all of these questions is like, what are the sort of systemic or cultural reasons why we do this why we do test you for these diseases at your annual physical, we don't test you for these things. And a lot of it comes down to how to cost. We've had a lot of talk about costs in the healthcare system. We spend the most of any country and don't get the results.
A lot back. Yeah. Yep.
I personally think that diagnostics are probably underutilized.
I agree.
Particularly when it comes to acute or infectious diseases. We got to a point in 2021 or 2022 where people got used to even testing themselves at home for COVID.
Right.
I don't think any of us want to test our own stool sample, so C. diff
I don't think so. Yeah.
Treated that way anytime soon, but we have had, because in the U.S., I think particularly pre-COVID, we'd had gains around HIV. We do have people that die from the flu every year, but the reality of it is that most of the deaths in this country, especially if you go sort of specific to diseases or disease categories, it's heart disease, it's cancer. And so those are the things that when you're getting your annual physical, the doctor's looking for, right?
Right.
And, you know, if you belong to a sort of subpopulation, like if people haven't ascertained this by now, like I'm a gay man, I'm
Right.
a Gen Xer, you know, my earlier activism was around HIV/AIDS, and that's, you know, I
Yeah.
think in some ways has helped me navigate this. But, you know, so someone like me, especially when I was younger and single, like I went and got tested for HIV every 6 months because
Yeah.
that was what we did then. There was
Yeah.
no PrEP, there was no, you know, the only prevention was condoms, and, you know, that made sense for us. It would not make sense for people that have been monogamously married for 20 years to get tested for HIV every 6 months. So
Right.
I think there
Exactly.
needs to be a sense of like, how do we tailor these things? Um, but I think the bigger issue is that right now, both through programs instituted under the Bush administration, the George W. Bush administration, and then through the Affordable Care Act, there is what they call value-based purchasing. And
Right.
so if you're a hospital and you take Medicare and Medicaid, which nearly all of them do, if you have a higher than they believe you should C. diff rate or MRSA rate, or, you know, 30-day readmission rates, there are a lot of things where you can then get penalized.
Right.
And so, you know, we hear that people are treating people presumptively, or they don't want to run a PCR test because it will show up as somebody having C. diff, even though they're colonized and maybe not sick. And so, so there have been almost like disincentives
Right.
to test for people. And it'll happen sometime next year, but the CDC is changing the way that it tracks these things.
Right.
They won't be going just with a lab result. They'll actually be going off the clinical diagnosis, which hopefully will get doctors to be like, oh, I want to know, you know. And, you know, it's something also like, if you've never heard of C. diff, you show up to the doctor and you are having diarrhea, like, you're not like,
Yeah.
could you test me for C. diff?
Well, exactly.
I mean, I would.
Exactly. Well, you would.
Um,
Yeah, for sure. I would
I
now,
also
for
feel like
sure.
I don't want any antibiotics, thank you.
Yeah. Well,
Not
yeah.
that, you know,
Yeah.
antibiotics are overprescribed.
Yeah, certainly. Antibiotics are
and
great, but you don't
recently
need
took-
it for, you know, stuffy nose, for sure. So you kind of touched on to my next the next point I wanted to talk about is that when I was preparing for this episode, we talked a little bit about this, I think, in the pre-interview and some of the background I received from you and some other things I was looking at. C. diff is not being tracked exactly, or the rate of it isn't really being tracked exactly by the CDC. You kind of touched on that. What's the reason for that? And I know you're doing your Peggy Lillis Foundation is doing something to help remedy that. So can you talk a little bit about that?
Yeah, so this is, similar to what we talked about in terms of like, why aren't people tested more readily for C. diff? You know, like, there's cultural reasons. There's, you know, again, like, if you are a general practitioner, if you're an emergency room doctor, like, you may have last heard about C. diff when you did your clinical rounds, or you were an intern,
Right.
or you did your residency. And back then, if you trained 15, 20, 30 years ago, it was very much an illness. Not even that, they considered it a nuisance disease. Where, meaning like it wasn't even that fatal that often.
Right.
But like we've seen with COVID and we've seen with other infectious diseases, like the bacteria or the virus can mutate. And so at some
Right.
point in the mid 2000s, C. diff mutated. It became more dangerous, more virulent.
Okay.
So that was what got the hospital tracking done, right? And for a long time, that did seem sufficient. But now they estimate that about somewhere between 40 to 50% of all of these cases are, at least people are getting symptoms first in the community. And what the Centers for Disease Control tracks is the hospital-based tests. So if you go and you get treated through your primary care doctor, or you go to an urgent care clinic, none of that will be tracked.
Okay.
And so what we're looking to do is to get C. diff to be made what is called a nationally notifiable disease.
Okay.
I think the simplest way to explain this is that if you watch your local news, or you go on Twitter, or there's a national recall, we just had one about, I think, carrots. There was
Yeah.
recently a recall of carrots because there was something found in them in a huge batch of them. That's because if one person gets E. coli from a fast food restaurant, that gets reported to the CDC
Right.
and to the local health department, and then they put out an alert. And that is what we'd like to see with C. diff. We don't think it needs to be on the 6 o'clock news, but we want, all of the cases reported, and we also want for us to be able to understand, like, if we're not getting half of the cases reported, then we can't really assess how the epidemiology is changing. Like, why is it younger people? Like, is there something underlying? Like, the community-acquired cases also tend to be people that have not been on antibiotics, which had been, like, the major precipitating factor.
That's interesting.
So we worked with my Congresswoman, Yvette Clarke, this past August. She introduced a bill called the Peggy Lillis CDI Inclusion Act into Congress that would more or less mandate the CDC add this to the list of nationally notifiable diseases. We have been in talks with the CDC. I mean, a lot of it comes down to, like, how much funding do they have? Like, how are we going to categorize these things? There's, pushback from hospitals and even state health agencies because they don't have the funding to take something else on. So it's understandable, but at the end of the day, like, we're here to advocate for patients.
Right.
And so, like, we're not, like, we don't think that those people are bad people, that people that disagree with us. We just think that they are responding to the incentives that they have, which is to keep costs down, to not add more, what do they call it? Like an unfunded mandate to their work. But at the same time, of the top 5 CDC urgent antimicrobial resistant threats, 3 of the 5 are nationally notifiable diseases, and only C. diff and 1 other are not.
Yeah.
So if something is considered an urgent threat, shouldn't we be tracking it?
Right.
In every way that we can. And so that's part of our argument. And we think that would help increase awareness. We think that would help, again, we estimate there's about 500,000 cases. They estimate that there's about 30,000 deaths. If we really tracked it, what if it's more? Then more funding. I mean, it's sad to say that we live in a culture where, like, to develop new drugs, you have to kind of prove that there's a market for them.
Yeah.
So if there's more cases of C. diff, if there's more like 1 million or 2 million, then there's more incentive for money, for funding, whether that's NIH funding or that's private funding. And, we want all of that. Because we want, 30,000 people dying from what is largely a preventable and treatable disease is just unacceptable to me.
Yeah. Well, I mean, you think about it in parallel it's about 30 to 40,000 people die every year on road accidents in the U.S. And that's a big it's something that's a high priority thing. Get those numbers down. Have more safety things in the cars and the airbags, and and you talk about DUI programs, etc.
I mean, I'm sure, because I think we're around the same age, Chris. Yeah. But, I suspect that both of us remember not wearing seatbelts.
Oh, yeah. Are you kidding?
Never heard of an airbag.
Yeah.
And also, maybe it's because I'm Irish Catholic, but, I certainly remember people driving after they'd had a few drinks when I was a kid. And admittedly, I myself did when I was a teenager, when I was college age.
Yeah.
But now we have road stops on holidays. And now people feel emboldened. If you or I were at a party together and one of us looked intoxicated and was trying to leave and drive home, we would say, no, you're going to sleep on my couch. I'm going to call you an Uber. You come get the car tomorrow. And so, but that's because, billions of dollars have been spent
Yeah.
Tens of billions of dollars probably to bring down driving under the influence, to invest in how do we make how do we make cars safer, how do we make impacts more survivable, and I think you can make the same argument around to make a more corollary like HIV, like
Yeah, exactly.
billions of dollars
Great
in education
example.
and awareness
Yeah.
campaigns, tens of billions of dollars spent developing treatments, preventatives. I mean, again, I'm a Gen Xer, but I have friends who are in their 20s and 30s, and all of them are on PrEP now. They're all
Yeah.
on the HIV prevention meds.
Yeah.
That wasn't an option when I was
Yeah.
out and dating and doing my thing.
Yeah.
But now it is. And so I
Yeah.
think we're going to increasingly see the number of people who get HIV to begin with and then who subsequently die from AIDS. At least in Western countries where there's resources, those things are declining kind of year
Yeah.
after year.
Yeah. Yeah.
And the same
And
thing
that,
with driving under the influence. We've had a huge change.
yeah.
Again, it's having the government, having institutions sort of, create, to go back to the driving thing, the rules of the road.
Right.
And then eventually it changes the culture to a point where people are like, oh no, I would never drive if I'd had a,
Yeah, exactly. Or you never drive without a seatbelt on. I knew people back in the day who, I'll never wear a seatbelt. They click the seatbelt on automatically now.
And
So yeah.
and now, I have I don't know if we mentioned this, but I have a 6-year-old nephew, and so like just from going and babysitting him and taking him places, me and my husband, like we got like a second hand from a friend, like they gave us their car seat. So when he was like 6 months old, we had a car seat in our car.
Yeah.
For like the 2 or 3 times a month that we drove him someplace.
Exactly.
We were thrown into the back seat of a.
Oh yeah, are you kidding me? Are bouncing all over the place,
bouncing around on the highway.
Yeah,
but
exactly.
Kids don't die in traffic accidents the way that they used to.
Yeah, for sure. It's
a very relatable thing.
Yeah, so it's interesting. Those are two good examples of public health. HIV, AIDS, and the traffic safety are two good examples of public health programs that have really paid off in a big way. That made society better, made individual lives better. We're so funny about public health sometimes in the U.S. I talk about that a lot with particularly with when I talk with international guests that
with the fear of lockdowns.
Yeah. So
that's. I would encourage anyone who works in public health or anyone who believes in science to stop calling what happened in the U.S. in 2020, 2021 lockdowns. I could leave my house whenever I wanted.
Right. Exactly. Yeah.
My grocery store was open. Like, yes, there were changes, and rather than losing 6 or 7 million Americans, we only lost 2 million.
Yeah.
So my personal inconvenience was
Yeah, for sure.
To save that many people's lives.
Well, in the same way, you get back to, I don't want to spend another 10 minutes talking about this, but just, that was the big issue. I remember when seatbelts were coming in, and particularly in American cars, no one's going to tell me what to do, and it's a big inconvenience to have to put the seatbelt. Well, now we all do it. And, we get used to it. We see the benefit of it. And the educational, and I think that's a big issue with a lot of public health. You and I probably could spend another hour talking about the problems with bad messaging on public health, and we both probably could one up each other on examples from now until doomsday. So, all right, so let's look broadly where we stand now. We talked a lot about some of the big challenges in the fight against C. diff infections. Is there anything our laboratory audience can do from your perspective, they could do to help raise awareness and get testing, or at least that that diagnostic mindset in their organization, in the organizations that they're working at, either in a hospital or if they work with a general practitioner? Is there anything that they could do from just from a grassroots education perspective from themselves? And we have pathologists, laboratorians, and lab managers who listen to our show. So we have a broad audience that can maybe get the word out.
Yeah, I mean, I think to the extent possible, like, PLF has worked with every sort of clinician group, from like doctors to infectious disease pharmacists to nurses to janitorial people. And so everyone has a role to play. And, I think making sure that, oftentimes the lab might be part of developing like what is they say algorithm. It's a kind of maybe not quite that complicated, but sort of like who does and doesn't get tested for C. diff.
Right.
We don't want to over test, but we also don't want to under test.
Right.
So I think being part of that conversation can be helpful. And I think, if you work in a lab, maybe, and especially if you're a lab manager or a pathologist, somebody that, does some speaking or is training other people, like, we have so many stories on our website. We have videos. We have many people that would come and be happy to speak at a conference of laboratory professionals and sort of really reinforce that what they're doing is part of healthcare and is a critical part of healthcare.
Right.
And I think that, it's easy when people work in a lab and you don't see them when you visit a hospital, or they work off site someplace, for people to forget the critical role of people who are running the diagnostic tests. It's not just that, your doctor, takes your blood and it disappears into the ether.
Right.
Like, there are people
Right, exactly.
actually doing these tests, right?
Right.
And so I think to the extent that, like, we can humanize those things, and, if there's somebody listening to this who has like an interesting story about C. diff, like, they could write a blog post for us. We'd be thrilled to share that information with people and how the role the lab plays. I think also for them, bringing, a story like my mother's or the other 200 stories we have on our website, when they're doing a conference, when they're doing trainings, it can just help people to understand how these things are interconnected. And really sort of bring the humanity to, like any of us, like, if you run 300 tests every day, it can kind of be hard to think of those as individual people, but they are.
Right.
And that's not a moral failing on anybody's part. It's just like we become numb to the things that we do every day.
Yeah.
And to have an occasional reminder of like, oh, this stool sample I'm testing, it's a person.
Yeah. Yeah. They're having that perspective, have that human perspective.
Yeah. Because, if I say 30,000 something, like, it's hard for us to even envision 30,000 of anything because it's so much.
Yeah.
I think it's also why, like, we don't do better advocating around how, like, our federal budget gets spent, because once you start talking about $1 billion, people are like, what?
Yeah. 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 It's just a one with a B behind it. Yeah.
We spend $10 million on this thing, and how dare we? And it's like, you spend $10 million like every second in the U.S. Like, we can get more money for public health.
Exactly. So, I always like to end on a positive, at least a forward-looking note. You've been, the Peggy Lillis Foundation's been in existence for, it's almost, 14, 15 years now. And you've seen a lot of changes. We just talked about your symposium. That did great. And, you're reaching legislators, etc. What, from your perspective, this could be good or bad. What do you think the diagnosis and treatment of C. diff look like in maybe the next 5 to 10 years?
So I think we're all aware that the next administration could be not as favorable to. So that is a concern. I think we have to stay aware and advocate and push back against anything that's going to endanger patients. But there is a part of me that is very hopeful, for the sort of medium to long term. Part of it is, I think we've had this kind of negative reaction to COVID, but at the same time, more people in the world understand, like, oh, there's this kind of test and there's that kind of test. And so I think people are, even if they're in denial about it, they are somewhat more aware that, like, we're breathing each other's air and, can potentially make each other sick. But I think for me, what's the most exciting thing is I do think that, professional studies are getting closer and as I mentioned earlier with the CDC and, recording a diagnosis from the clinician as opposed to a lab test, we're getting closer to like having a great way to track C. diff that isn't confusing or garbled. And then I think the other part of it is that, up until about maybe little less than 2 years ago, if you didn't respond to antibiotics, or if you had recurrent C. diff or severe C. diff, like the only option you had was a fecal transplant, which means taking the stool of one healthy person and giving it to the sick person. We have worked almost at every level, from helping recruit for clinical trials to testifying at FDA advisory committee hearings. And we now have 2 microbiome therapies approved.
Oh, wow.
So one is given rectally, the other is an oral thing that you can take for recurrent C. diff. And so I think we're at the precipice of looking at like, how do we work with the body's existing microbiome to restore it, to balance it? First of all, that's great for C. diff, and it also helps us to maybe not use as many antibiotics.
Yeah, for sure.
And then so the existing microbiome therapeutics and preventives, they're all for people that have had recurrent C. diff. But we just talked to a company that has developed one that would be for a first-line treatment. So this would mean that person doesn't even get any more antibiotics if they had them in a cause C. diff. They just immediately go to this microbiome restoration thing. And I think, antibiotics are critically important. They underpin almost every kind of medicine that we think about, from surgery to cancer treatment to immunosuppressive therapies. We're not developing them. So that is a very scary, potentially existential thing. But at the same time, if we can move away from the idea that, you have a bacteria, you have a virus in us, let us kill it. Instead, if we can say, like, well, how do we promote a healthy microbiome? How do we support people having a strong immune system so that viruses can't latch on to them, So I think that that's the direction that we want to push people, and it's everything from, are you eating a diet that supports your gut microbiome? Like, if you have to take an antibiotic, is it a targeted one? Is it the least, the one that's going to be least damaging to your gut microbiome?
Right.
So I think, we can be more intelligent about this. And I think obviously part of that is also, what the public is going to demand.
Yeah. Yeah. Well, that's as we talked about earlier, that a lot of it sometimes comes down to those grassroots push. And certainly what you're doing to help with that push is great. And unfortunately, we've come to the end of our time. But Christian, thanks so much for taking the time to walk me through and our audience through the challenges of diagnosing C. diff and treating it, and all the great work that Peggy Lillis Foundation is doing. And I also want to thank you, the laboratory audience, for listening. Look for more episodes of Clinical Lab Chat in the future, and visit us online at clpmag.com and on all the major social media platforms. So until next time, be well.